I'd like to first of all thank Dr. Espinoza for that wonderful lecture that she gave on surgery of babies with necrotizing enterocolitis. And I think that with my lecture, we need to consider the possibility that we'd like to never have the surgeons ever have to operate on a baby with necrotizing enterocolitis in the future. This is a terrible disease, and once it starts, we have a very difficult time stopping the disease. So prevention is going to be, I think, the wave of the future for necrotizing enterocolitis. So again, this is a picture that I showed you previously. Again, a baby with sort of the classic form of necrotizing enterocolitis. And I call this classic for a very good reason, and I'll get to that shortly. Over this lecture, I'd like to give you a little bit of background, and I want to talk about the fact that necrotizing enterocolitis is not just one disease. It's more than one disease. I want to talk a little about what we know about the pathogenesis of the classic form of necrotizing enterocolitis. Where are we going in the future? Can we develop predictive or diagnostic biomarkers for this disease? And then can we have preventative strategies? So let's look back into history. And when you think about necrotizing enterocolitis prior to about 50 years ago, and if you look at the textbooks, for example, Schaefer's textbook of diseases of the newborn, you find just a few lines about this disease, about necrotizing enterocolitis. And so over the last 50 years, with the development of modern intensive care, where we are saving a lot more premature babies than we ever saved before, this disease has become very, very prevalent. And in fact, it's become so prevalent that we are really not decreasing the incidence of this disease. If anything, it seems to be still increasing. What are some of the problems with our progress in this disease? Well, here are some sheep that are crossing a road, and sometimes you have one sheep that goes in front of the group and the rest follow. And this can be very dangerous in terms of science and in terms of clinical care, because sometimes we just think within a certain manner and don't think outside the box. And I think that this has been one of the problems with necrotizing enterocolitis. Necrotizing enterocolitis is really more than one disease. When you think about diabetes, diabetes is more than one disease. You can have type 1 diabetes, you can have type 2 diabetes. They can end up manifesting in very similar ways, but they're really different diseases. Cancer is more than one disease. There are very different forms of cancer. Well, necrotizing enterocolitis also, at least what we are calling necrotizing enterocolitis, is more than one disease, and I'll talk about that shortly. And we also have some problems with the animal models that we have been using to help us understand necrotizing enterocolitis. Most of the animal models that we have been using do not really represent the disease that we see in preterm babies. So let's talk about the fact that necrotizing enterocolitis is more than one disease. We have some babies, especially babies that are born at term, who have cardiac disease, babies with hypoplastic left ventricle, babies who have interrupted aortic arch. Those babies have a problem with blood flow to their gastrointestinal tract. Those babies can have ischemic intestine. This is not the same disease that we see in most of our premature babies. We have some babies with severe polycythemia, hematocrits greater than 70, that have hyperviscosity, which causes lack of blood flow to the gastrointestinal tract. This is not the classic form of necrotizing enterocolitis. We have some babies who develop pneumatosis intestinalis and signs of necrotizing enterocolitis who actually have congenital abnormalities of the gastrointestinal tract, such as Hirschsprung's disease, intussusception. Those babies do not have the typical necrotizing enterocolitis. Then we have some babies with spontaneous intestinal perforations. Those babies do not have necrotizing enterocolitis. This is a different disease. We're beginning to recognize more and more that some of our babies have actual food protein intolerance or food protein intolerances that seem to appear after you introduce certain formulas or certain fortifiers to their feedings. And those babies can develop very bloody stools and pneumatosis intestinalis. But they do not have the same kind of disease that we see in classic NEC. And then we have the classic form, which is an inflammatory process, which probably is preceded in most cases by something called an intestinal dysbiosis, where you have microbes that change in the wrong manner, where we have not the commensal types of microbes forming in the gastrointestinal tract, but rather pathogenic microbes. So let's talk about some of these situations. Here we have two x-rays. One is an x-ray right after birth, and one is 12 hours later. Do you see a difference? Yes, okay, obviously there's a difference. Here you see free air in the peritoneum. This baby was taken to surgery, and in the ileum, this baby had a little bit of a perforation, but no necrosis of the bowel. This is spontaneous intestinal perforation. This is not necrotizing enterocolitis. It's a different disease than necrotizing enterocolitis. But oftentimes in databases, you find that spontaneous intestinal perforations do get mixed in with necrotizing enterocolitis. Spontaneous intestinal perforations tend to occur early, usually in the first week after birth. They occur in very small babies. They're not associated with feedings. If anything, they're associated with lack of enteral feedings. And we see a very high association of spontaneous intestinal perforations with the combination use of indomethacin and glucocorticoids. We have this staging criteria for necrotizing enterocolitis called Bell's staging criteria. Bell's, this comes after a person's name. It's not Ed Bell. Ed Bell's a very good friend, but Ed Bell says that this is a disease that people think were named after him, but it was not named after him. It was named after Martin Bell, who is a pediatric surgeon from Kansas. And there are three different stages of the Bell's criteria. These were developed in the late 1970s. And stage one is very problematic. Why? Because it's very nonspecific. When you have stage one, this means that you can have a little bit of abdominal distension. You can have a baby who may be having increased gastric residuals, who may not be looking very good, who may have just a little bit of blood in the stool, but no definitive signs of necrotizing enterocolitis. Stage two, as Dr. Espinoza said before, can also be problematic because you can have different people taking a look at x-rays. And especially with the nonlinear form of pneumatosis, different people will say this is pneumatosis, other people will say this is actually stool, giving a bubbly appearance in a radiograph. And so this is problematic. Stage three, you can have a baby who develops surgical looking disease. In other words, where you have pneumoperitoneum and the surgeon will place a drain, but you don't really look at what's going on in the gut. And if you just place a drain and if you don't see exactly what is going on in the gastrointestinal tract, you can put that down in your database as necrotizing enterocolitis. But it is not necessarily necrotizing enterocolitis. So what we put in our databases as necrotizing enterocolitis can be problematic. And so using these staging criteria, I think we need to start getting away from this. We need to get a better definition of necrotizing enterocolitis. What about the pathophysiology of this disease? Well, we think that it's a combination, it's a multifactorial disease, usually associated with prematurity and various immaturities of the gastrointestinal tract, including poor motility, including an innate system, which is not an innate immune system, which is not yet fully developed. There may be a genetic component. If you have identical twins in a neonatal ICU, it appears that the identical twin, if one twin gets it, the other twin may have a higher likelihood of development of the disease. But actual mutations or areas of DNA that have been clearly causal with the development of necrotizing enterocolitis have not yet been found. And then another, what we think probably strong association is the types of microbes in the gastrointestinal tract, and I'll talk about these shortly. So what about the animal models of necrotizing enterocolitis? This is a form of an animal, one of the animal models that's used for looking at necrotizing enterocolitis. And this was developed by Doctors Pitt and Barlow at Columbia University in the late 1970s. And there are now approximately 192 publications in PubMed that use this particular model of necrotizing enterocolitis. Well, how does this work? Well, here we have some baby animals that are put into this plastic bag. The plastic bag is closed, and you allow these babies to rebreathe their air. They turn purple. They begin to gasp. They're almost dead of asphyxia, and then you take them out of the plastic bag. And then you put them into a refrigerator, and you subject them to cold stress. And then you take them out, and then you feed them a formula that is very different than what they would be getting from their mothers. And guess what? In about 2 or 3 days, these baby animals develop intestinal necrosis. They are also very sick animals. Is this the disease that we see in most of our premature babies? Well, let's look at this a little bit more closely. Here we have 2 preterm babies. This baby was born at around 23, 24 weeks gestation. This baby was born at around 28 weeks gestation. When does this baby develop necrotizing enterocolitis? And when does this baby develop necrotizing enterocolitis? In general. Well, several years ago, I had one of our postdoctoral fellows look at the data at the University of Florida, and here we see gestational age, and this is age at onset of necrotizing enterocolitis. So here we have our 23-week gestation, 24-week gestation premature baby who develops at around 6 weeks after birth, and our 28-week gestation baby develops at around 2 weeks after birth. This has been seen in several studies. The Neonatal Network has seen this. Pediatrics with the conglomerate of private neonatal ICUs. We've seen that in various large databases that most necrotizing enterocolitis, the classic forms, do not develop right after birth when these babies would be potentially asphyxiated or where there's an increase in feedings or the kind of anomaly that you saw with these rats that I just showed you. So that rat model does not represent what we see in the human situation. We don't know why these babies seem to develop this at around 29 to 32 weeks, but it may have something to do with a developmental issue, similar to retinopathy of prematurity. With retinopathy of prematurity, you have a microvasculature of the eye that is just beginning to develop at a certain stage. The same thing may be happening with necrotizing enterocolitis. But we also have other things developing in the gastrointestinal tract of babies with necrotizing enterocolitis. And I just want to backtrack a little bit and mention ischemia reperfusion. And I think that we're beginning to recognize that ischemia reperfusion injury is not a major cause of necrotizing enterocolitis, that we have other major factors associated with this disease. And for the most part, this is an inflammatory process because we see high levels of inflammatory mediators such as IL-6, IL-8, increased platelet activating factor associated with this disease when it develops. This is a study that was done at Harvard, Massachusetts General, with Dr. Alan Walker's group, and they asked the question, does the immature intestine have a greater propensity toward inflammation than the more mature intestine? So what they were able to do was take small pieces of human intestine from abortuses at different gestational ages, and they compared these pieces of intestine to more mature individuals. And so what they found was that if they put these little pieces of intestine in a culture media and then treated these pieces of intestine with LPS, lipopolysaccharide, they were able to get differences in inflammatory mediator response. Here we have the infant. This is the older, the more mature individual, has a very small response in IL-8 to LPS. And this is the fetus, the very immature individual, has a much greater response to LPS. So this is telling us that the more immature the individual, the greater the response to an inflammatory stimulus. It's a very important factor. What about the microbes in the gastrointestinal tract? Do they differ prior to the development of the disease? This is one of the studies that we did at the University of Florida, and the way that we did these studies was that we were able to collect stool samples from babies at 3 different hospitals, 2 hospitals in Jacksonville, Florida, 1 hospital in Gainesville, Florida, and we collected stool samples weekly throughout the hospitalization of babies 32 weeks of gestation or less. And we kept these in our freezers, and those babies who developed necrotizing enterocolitis, we were able to take the samples from those babies who developed necrotizing enterocolitis and then compare them to closely matched controls. So here we have some of the data, some of the outcomes of the types of microbes that we see in the control infants and those babies who develop necrotizing enterocolitis. So here we have those babies who develop necrotizing enterocolitis, and these colors represent different phyla of bacteria. And here we see that 1 week before the diagnosis, compared to 72 hours of diagnosis, there's this increase in the purple. The purple is a type of bacteria, a phylum of bacteria called the proteobacteria. We do not see this bloom in the controls. So there's a change in the types of bacteria prior to the development of necrotizing enterocolitis, this bloom of proteobacteria. Work that was done by Erica Claude and colleagues at University of Chicago seemed to support this. This is from one of her papers looking at a set of twins. One twin developed necrotizing enterocolitis, the other one did not. This is the healthy twin, and you see that there is no change in these colors, so no change in the types of microbes. And this is a baby who developed necrotizing enterocolitis, and you see that there is a shift of firmicutes. This is a type of microbes which actually decreased, but the proteobacteria increased. What are proteobacteria? It's a major phylum of microbes that consists primarily of gram-negative microbes that are high in pathogens. The E. coli, Salmonella, Vibrio, Helicobacter, Klebsiella, and Pseudomonas belong to this phylum of bacteria. These are gram-negative microbes with a membrane that is very high in lipopolysaccharide, LPS. They've been associated, these microbes have been associated with exacerbations of inflammatory bowel disease. So in older individuals who have Crohn's disease or ulcerative colitis, if they have exacerbations of their inflammation, they see these types of microbes increase in their gastrointestinal tract prior to the exacerbations. So these proteobacteria may play a very likely role. Very recent study, which is not yet published, but working with one of the physicians from Baylor University. We have done a meta-analysis of the various studies that have done 16S sequencing of the microbes prior to the development of necrotizing enterocolitis. And we've looked at, Dr. Pammy and I have looked at 7 different studies, and we also see this bloom of proteobacteria in this meta-analysis of 7 different studies. So this appears to be real. So what happens in summary in terms of the pathophysiology of the inflammatory form of necrotizing enterocolitis? You have an altered microbiota, perhaps with a genetic background, predisposition, with an innate immune system. And this is very important because studies that were done by Dr. Hackham and colleagues show that the TLR4, toll-like receptor 4 system, seems to be very high in the last trimester of pregnancy. It goes up in the last trimester of pregnancy, and then it drops. And so this TLR4 system, is highly responds highly to lipopolysaccharide. And if you have lipopolysaccharide increasing with this TLR4 system increasing at the same time, you have a very strong predisposition for the development of this inflammatory condition at that period of time. So this 29 to 32 week gestational post-conceptional period is a very susceptible time, probably because of those factors. So we think that dysbiosis is very important in the pathophysiology of necrotizing enterocolitis. What are some of the things that we do in neonatal intensive care that may actually contribute to this dysbiosis? Well, one of the things is sometimes we don't feed babies by the enteral route. And I talked about this in my first lecture, that lack of feeding can actually cause some problems. Lack of feeding can cause intestinal atrophy. It can cause an increased inflammatory response, and it can also lead to opening of tight junctions and hyperpermeability of the gastrointestinal tract. So feeding is thought to be important, and I showed you this slide before. This was done in adult mice, and here we see adult mice who were fed, and you see these microbes here. These are primarily the firmicutes, and here is an unfed group that is getting TPN. This blue represents, guess what? The proteobacteria. Very high in proteobacteria in those animals who were not being fed. This is a study from Cami Martin from Harvard. And the title of this is Late Enteral Feedings Are Associated with Intestinal Inflammation and Adverse Neonatal Outcomes. And here we see, this, I showed you this before, babies who are fed early versus late. There's a higher necrotizing enterocolitis in those babies who are fed late. In addition, there are other adverse outcomes in those babies who are fed late compared to those babies who are fed early. And if you look at 2 weeks of age, the blood inflammatory markers in these babies, those babies who are fed late have higher levels of IL-8. Those babies who are fed early have higher levels of IL-1, interleukin receptor antagonist. This is actually a good cytokine, and early feeding leads to a higher level of IL-RA, interleukin receptor antagonist. And here we have IL-10 is higher in those babies who are fed early. This is an anti-inflammatory cytokine. What are other things that we do in neonatal intensive care that can cause problems? Well, here we have a slide that shows the top 10 list of NICU medications. What's at the very top? Ampicillin and gentamicin. We also have, further down here, cefotaxime, vancomycin. So of the 10 most commonly used drugs in neonatal intensive care, 4 of them are antibiotics, and at the very top are ampicillin and gentamicin. What about ampicillin and gentamicin? Can this cause problems? Can this actually predispose to necrotizing enterocolitis? Well, here we have a slide, and this is one of 3 different studies that show this association. Here's days on antibiotics. Here's the odds ratio of development of necrotizing enterocolitis. So increased days on antibiotics, increased odds ratio of development of necrotizing enterocolitis. Most preterm babies in our neonatal ICUs get about an average of 5 days of antibiotics. So that increases the odds ratio by 50% development of necrotizing enterocolitis. Here's a study from University of Cincinnati looking at antibiotic usage different levels of antibiotic usage. Here's 0, here's just a little bit of antibiotic usage, here's a lot more, and here you see late onset sepsis, necrotizing enterocolitis, and death, all increasing with increased use of antibiotics. Here's a slide that shows the acid output in the stomach of preterm babies. And these are 32-week gestation babies. Here is postnatal age in weeks, and here's acid output. And here you can see there's very little acid output in the first few weeks. This is with pentagastrin stimulation, a little bit more, but both of these plateau at around 3 weeks. So this is telling us that there's very little acid output in the stomach of preterm babies. What does that have to do with necrotizing enterocolitis? Well, in the past, we have used a lot of H2 blockers in neonatal intensive care. Why? We use these H2 blockers because we think that apnea and bradycardia is secondary to gastroesophageal reflux. That relationship has been found to be non-existent, or close to non-existent. Okay, so the use of these H2 blockers for apnea is not a good idea. Why? Here's one study that shows that ranitidine is associated with infections, necrotizing enterocolitis, and fatal outcome in newborns. This is a study from Italy looking at several different neonatal ICUs. There are several studies now showing this relationship. Now let's get back to what happens in the gastrointestinal tract. This is a study that was reported in the Journal of Pediatric Gastroenterology and Nutrition in 2013. And here we see IV H2 blocker being started. And guess what this bacteria is, the relative abundance of this bacteria. And guess what this one is? With the use of H2 blocker, you increase the proteobacteria. And the firmicutes are fairly low. Remember what the proteobacteria do? Those are the bad guys in the gastrointestinal tract. Okay, then they stopped the IV H2 blocker. Proteobacteria went down. Firmicutes, the good guys, went back up. Then they decided, let's start it again. Let's start at PO. And what happened? Proteobacteria went back up again, and the firmicutes went back down again. So H2 blockers cause this change in the types of microbes in the GI tract. And again, we see this association between the proteobacteria and medication that we give in neonatal intensive care that may be associated with necrotizing enterocolitis. So as far as the dysbiosis in necrotizing enterocolitis, I didn't talk about this very much, but the dysbiosis may actually start before birth. And we've gotten this suggested association between certain taxa of bacteria and necrotizing enterocolitis that seem to make sense. But at this juncture, right now, we still have not proven that these particular bacteria cause necrotizing enterocolitis. We have to have some further experimentation that fulfills Koch's postulates. We are in the process of doing that in our laboratories. There are other neonatal groups that are doing the same thing. Now, other things that can prevent necrotizing enterocolitis, I showed you before, human milk, especially baby's own mother's milk, can decrease necrotizing enterocolitis. And here we talked about this before, that donor human milk may not be as potent in preventing necrotizing enterocolitis as using baby's own mother's milk. And this is a slide that I showed you before, that using donor milk versus formula, there may not be that much difference. So donor milk may not be the best preventative measure, and I think, as I said in my previous lecture, we should be aiming toward using baby's own mother's milk if at all possible. What about the future? Here we have 2 x-rays. Are these normal? Are these normal x-rays? No. I see a lot of you shaking your heads. Is there pneumatosis intestinalis? No. There's no portal venous gas either. Is there definite sign of perforation? Is there free air? No. So here's where we have a diagnostic dilemma. We know for sure that something is going wrong here with these babies, but This is very difficult. So I've seen this situation many, many occasions where we discuss this with our pediatric surgeons, our neonatal surgeons, and we have this discussion about should we operate, should we not operate on a baby like this. This is a very, very difficult decision. We have to have better biomarkers for babies like this. The types of biomarkers that we have been using for the most part are platelet count, white blood cell count, C-reactive protein. They're somewhat helpful. They tell us that there's an inflammatory process going on, but they're not specific for necrotizing enterocolitis. They will not help you differentiate necrotizing enterocolitis from sepsis. So we have to have more specific and sensitive biomarkers. There are some studies that have been done on calprotectin and calgranulin, okay? These are enhanced non-specific biomarkers. These are found in the feces. You have to get stool samples to do these. And actually, fetal calprotectin seems to have a fairly high specificity and sensitivity. But the problem is that you can't tell a baby when to poop. You just can't necessarily get a stool sample from a baby whenever you want. You have to have a better source. So we have some other biomarkers that have been studied, and there are several studies on these biomarkers now: intestinal fatty acid binding protein and claudin-3. Claudin-3 is a tight junction protein. Intestinal fatty acid binding protein is an intracellular epithelial protein. So if you have a breakdown of the intestinal epithelium, you will see an increase in intestinal fatty acid binding protein in the urine, and the same thing you will find with claudin-3. You will find these in the urine and in the bloodstream. They are highly water soluble. And here's a study from the Netherlands which shows that these two agents have a fairly good sensitivity, specificity, and predictive value in good areas under the curve. So we have these biomarkers which are in the process of being developed, which may help us in the future in terms of diagnosing this disease early. There's also an interesting study that has come out in the last year, also from the Netherlands, and the title of this is Early Detection of Necrotizing Enterocolitis by Fecal Volatile Organic Compound Analysis. If you have a change in microbes in the gastrointestinal tract, this change in microbes can cause a change in the types of metabolites that are produced in the gastrointestinal tract. So the technique they are using is something called e-nose, electronic nose. What they do is they take some stool samples from the babies and volatilize these stool samples and then subject them to gas liquid chromatography, and you're able to find certain metabolites in the stools that suggest necrotizing enterocolitis. There's a nationwide study being done in the Netherlands right now looking at this technique to see how predictive this technique might be for the development of necrotizing enterocolitis. What about probiotics? Are you using probiotics here in your neonatal ICUs? Anybody? Some people say yes, okay. So are we there yet? About 15% of neonatal intensive care units in the United States are using probiotics. How do we get there? Well, in 2010, in pediatrics, Giresh Deshpande did a meta-analysis. In this meta-analysis, they evaluated 11 different studies where 10 different probiotics were looked at. In this meta-analysis, they found that the risk for necrotizing enterocolitis and death was significantly lower in the probiotic group. Sepsis did not differ. In the discussion section of this paper, and I quote, they said, the overall evidence indicate that additional placebo-controlled trials are unnecessary if a suitable probiotic product is available. There was another article in the same publication, in the same journal, that suggested that it was now unethical to not use probiotics. In neonatology, we've had some real problems with overexuberance. And we've had some misadventures in neonatal intensive care where we've been very excited about new techniques. These are just some examples of new techniques that were found to really not work very well, but actually cause damage. And so many of us have been a little bit concerned with routine use of probiotic and rapid institution of probiotics in neonatal ICUs. And this is just one article that I was asked to write a commentary on in Journal of Pediatrics a few years ago. This is one that Cammie Martin wrote in Journal of Pediatric Gastroenterology and Nutrition, suggesting that we need to be a little bit careful with moving forward with probiotics. Why? Well, first of all, what are probiotics? Are they a drug or are they a food supplement? If we have a health claim, then this should be considered a drug. Here we have a health claim that probiotics will prevent necrotizing enterocolitis. Drugs that are sold by prescription are subjected to rigorous testing, whereas foods are not. So far, the types of testing that has been done with probiotics has not been the kind of rigorous testing that you find with drugs. A little bit over a year ago at Yale University, there was a baby who was being given ABC Dophilus, very commonly used probiotic. The baby died, and the pathologist very astutely noted that this baby had something in the bowel that looked very strange. And he cultured this material in the bowel and found that it was mucormycosis. They traced that back to the product, the ABC Dophilus product that was produced by this particular company. This was a tainted product. So this was taken off the market. What about the studies that we have? Sometimes when you have a meta-analysis, if you put garbage in, you get garbage out. Okay? I don't want to say that the studies that were placed into the meta-analysis were necessarily garbage. Some of them were actually fairly good studies, but none of them were actually powered for necrotizing enterocolitis. Here's a study that was done in England that was powered for necrotizing enterocolitis. Double-blind randomized prospective study using one microbe, Bifidobacteria breve probiotic, given to babies 23 to 31 weeks gestational age. And the results of the study in 1,315 babies was that there were no differences in necrotizing enterocolitis, late onset sepsis, or death. No differences. So we have the largest study thus far that was really done well, not showing any differences. We have other compounds that are being looked at in terms of preventative measures, microbial therapies such as prebiotics and combinations of pre and probiotics, including human milk oligosaccharides. There are certain human milk oligosaccharides that are not found in cow's milk that appear to promote certain kinds of bacteria, the bifidobacteria growth in the gastrointestinal tract. There are also some studies, very early studies being done on ecotherapeutics, replacement of a dysfunctional ecosystem with a healthy ecosystem of native intestinal bacteria, somewhat similar to fecal microbial transplantation. Very early stages of doing studies similar to that. So as far as probiotics are concerned, there are no current standards for quality control of probiotics. And there's, unfortunately, with the 15% of neonatal ICUs that use probiotics in the United States, many of them have been using off-the-shelf compounds. Some of the probiotics are not even those probiotics that have been studied in the meta-analysis. At this juncture, the FDA has approved 2 studies that meet the standards for drug studies. These are currently being done. So I'd like to stop here with some take-home messages. Necrotizing enterocolitis is more than one disease. The pathogenesis of the classic form of necrotizing enterocolitis is multifactorial. but there are some factors, such as the gut microbial ecology, that may be more important than other factors. Predictive and diagnostic biomarkers are needed for targeted prevention and therapy. These are being worked on. For now, early nutrition, especially enteral nutrition with a baby's own mother's milk, can be preventative. You want to avoid certain medications if at all possible, such as antibiotics and H2 blockers. Be aware of the downside of probiotics. They are not all the same. The quality of some of these products is questionable. There are promising preventative measures which may be on the horizon, but I think we need to proceed carefully. Thank you for your attention.